Okay, good afternoon and welcome to the first board meeting of NHS Improvement since our formal start on the 1st of April. Welcome to members of the public, welcome to members of the public who will see the proceedings of the public board on our website because it's being filmed this afternoon, the first time that the board meeting of Monitor, TDA and NHSI has been filmed, and I hope that colleagues regard that as a positive. In that context, I'm required to ask board colleagues if they are content with this part of the board meeting being filmed.
Yes.
Thank you very much. So this is the first board meeting. We're a very significant NHS board to discharge very significant responsibilities to the NHS. I welcome new board members, and I think if we just quickly go around the table to say who we are and where we're from, we'll do more engagement on that type as we go through the development sessions of the board. But Richard.
Richard Douglas, new non-executive and chair of the Audit Committee, formerly Director General for Finance in the NHS Department of Health.
Catherine McLean, Medical Director, NHS Improvement, formerly Medical Director at the TDA.
Ara Darzi, I'm a surgeon in the NHS.
Sigurd Renton, I'm a non-executive director and I chair the Technology and Data Assurance Committee of this board. Prior to that I was on the board of Monitor, and before that I chaired various NHS trusts.
I'm Glynis Breakwell, I'm a new non-executive director. My other job is to be the Vice-Chancellor of the University of Bath.
Good afternoon, my name is Ruth May. I'm the Executive Director of Nursing of NHSI and previously the Nurse Director for Monitor.
Hi, good afternoon. I'm Caroline Thompson. I was a non-executive director of the TDA, and before that I was Chief Operating Officer at the BBC and Executive Director of the English National Ballet, so I'm in a slightly different perspective perhaps, and I'm Chair of the Appointments Committee.
Good afternoon, my name is Stephen Hay. I'm Executive Director of Regulation at NHSI. Prior to that I was Managing Director of Regulation at Monitor.
Laura Carstensen, I'm a new non-executive director. To summarise, I guess I'm a lawyer by background but not practiced law for a long time now. Probably most relevantly in this context, I have been Deputy Chairman of the Competition Commission. I was a board member at the Cooperation and Competition Panel for 5 years up to its absorption into Monitor. I'm a Commissioner at the Equality and Human Rights Commission. I'm very interested therefore in issues of leadership and diversity in leadership. And I've actually been a non-executive director of a foundation trust also as well.
Good afternoon, I'm Bob Alexander. I'm the Director of Resources for NHSI. Previously I was Chief Executive of NHS Trust Development Authority, having previously been its Finance Director.
Hello, I'm Sarah Harkness. I'm a non-executive director who joined from the TDA. Prior to that I was a non-executive director in the Strategic Health Authority for the North of England. My background's in corporate finance. I'm now also Pro-Chancellor at the University of Sheffield.
I'm Jim Mackey, Chief Exec of NHS Improvement.
Ed Smith, Chair.
Jessica Dahlstrom, Head of Governance.
Kate Moore, General Counsel.
Good, got that bit over with. And we're missing Pat Carter today, sends his apologies for the meeting, and Sir Peter Carr, who remains a board member until the end of May, and Peter has sent his apologies. By way of opening remarks, I mean, it goes without saying that we as a board will conduct our affairs with proper and effective governance on all key issues. The board operates on the basis of no surprises, so we expect to be kept apprised of things that are going on by the executive, and I will, as best I can, make sure that all non-execs are aware of issues before, shall we say, they hit the public domain. We are moving very fast as a board in a whole range of activities in difficult circumstances for the NHS, but I'm delighted of the amount of collaboration that is now in existence between ourselves, NHS England, CQC and other constituent parts of the service. And indeed this morning Jim and I have been in a meeting with chairs from providers of acute hospitals, mental health trusts, community trusts and ambulance trusts, talking about the issues that providers are facing and the importance of collaborating in local health economies. We're going to run a delegated board with 4 principal committees and an improvement faculty. We will also have task and finish groups, because I am of the view that task and finish groups, which bring together colleagues from around the system to deal with a particular issue over a 6, 9, 12-month period, and then are disbanded, is a really fast and effective way of dealing with some of those things. And we're also going to be engaged very closely with our stakeholders and other parts of the system. Malcolm Grant and Simon Stevens have already been invited to join our board meeting at a future date alongside Peter Wyman and David Bean. So I hope that meets with the expectations of collectively engaging in this system. I'm also hope you welcome the view that we should have board development itself, so that we develop in the way that we are supporting the system to develop and to improve. And I will be, with your agreement, appointing a facilitator to lead that process for the next 12 months. I think that's the best practice, and Jim, you will be doing the same with your executive.
Absolutely.
So we might get into that later during the course of the afternoon, but they're just a few opening remarks. If we move on, are there any declarations of interest that have not already been declared and in the register? For those of you who were present at the meeting on the 22nd of March, are the minutes a fair record of that meeting? There are no points that colleagues wish to raise. And in terms of matters arising and the action log, Jessica, do you want to?
Yes, there are a few actions outstanding, but they are all in hand. So it's principally a number of notes that will come to the board shortly, including on data validation, on 7-day services, and on the operating model. In fact, will be discussed later this afternoon.
Are there any matters that colleagues would like to raise with respect to matters arising? And are there, would any colleague like to unstar the items starred in the public meeting agenda, which are the pricing update and the corporate report?
In the corporate report, there are 2 small points I'd like to highlight from the report on the TDAC.
Okay, so we'll unstar that and come back to it. And the purpose for new colleagues is, as it sets out in the agenda, if an item is starred, it's deemed to have been read, agreed, without discussion. But I am incredibly open, as always, to those items being unstarred. It just allows us to manage the agenda to work that way. Jim, Chief Executive's report.
Thanks, Ed. So I'll draw out a couple of issues specifically. I'll read through this line by line, and there's a couple of additional things that I think we should just reflect on today. So first of all, we had a really good meeting with the Chief Exec's Advisory Group in early April. Talked a lot about earned autonomy, which is very much where we want to be in terms of how NHSI works. So we're pulling thoughts together with NHS providers on that, and we'll have a board discussion hopefully next month or the month after. At that time, we're at the height of the contract negotiations process, and I'm glad to see a lot of those tensions and difficulties have now been resolved, although we will still be left with a residual challenge which between us and NHS England will be working on over the next couple of weeks to try and find a way of resolving those issues so that the NHS has the chance it needs to have in terms of resolving its financial issues, etc. in the coming 12-18 months. 2 weeks ago today I went to visit Colchester Hospital, which has had quite a hard week this week in the media and for obvious reasons relating to special measures. And I think it's very easy to take a very negative view of organisations that have been in difficulty. But what I saw, and I know colleagues have seen recently, is a lot of hard-working clinicians who recognise that they've had some difficulties and have accepted them and started to deal with them. they're by no means in a perfect state and won't be for quite a long time, if ever, and have recognised they also need to have a partnership with Ipswich. I just wanted today to record that we have seen a lot of progress there, not sufficient for where we want to be at the right pace, etc. But I think the staff there deserve some recognition for that, and the current leadership. So with the board's support, I will write to the team to reflect those thoughts. And then also a bit of reflection. It's been a bit of a difficult week for the NHS with the industrial action. And again, this afternoon Simon and I will write to NHS providers to thank them for their incredible efforts this week to make the system work in very, very difficult circumstances. Nobody wants to be where we are, but the NHS has done what it always has done in a crisis. It's pulled together and it's managed very difficult circumstances incredibly well. So again, on your behalf, we'll write with thanks, and as part of the preparation for what might be another stage of industrial action later on. So other than that, I'm happy to take any questions or comments from people.
Laura.
Jim, can I ask, do we have an external engagement strategy, or do these sorts of visits or roundtables and so on, are they essentially driven by events?
We don't have a well-formulated strategy yet, but we need to develop one.
Yes.
Ed's got some visit protocols. I've got a similar thing being developed, but I think as a board we could do with Ruth and others, and Kathy and others are out all the time. We could do with a more coherent plan
More
for that.
strategic plan.
Yeah,
Yes,
absolutely.
good. Okay,
Yeah.
thank you.
Just a couple of things to add to that, Laura. There are regional meetings of chairs of trusts as well, and that was part of the way in which TDA in particular operated. I have been to now a full cycle of those over the last several months, and we're very, very keen that those quarterly meetings become part of the engagement of the whole board with trust chairs. So I'm going to be inviting non-execs to go to those meetings, as well as obviously a more programmatic engagement. And it was great that you could join us over a sandwich lunch after our chairs advisory meeting to engage directly with chairs of institutions. But certainly visiting providers is really important.
I'm all for it. I just think it's better if it's planned and strategic generally.
No, sorry, the point was Monitor had a planned programme where NEDs were expected and to have a routine programme of visits to provider trusts of one kind. I would simply suggest we resurrect that.
Kathy.
Just to add further to that, there's I think the depth of this goes all the way down. So myself, Ruth, others all go out, and I think we have both the planned engagement at kind of regional and national, but also organisations who you do need to visit for all sorts of reasons, and then those where there's really good practice you want to go and see, so you can be part of that spreading across the system. And I think we are building gradually the sort of slightly strategic approach to all of this, so there'll be something clear, but then there's always the ad hoc as well, so it's good to get out.
Thank you.
Last one on this subject, Ruth.
Thank you. I've just returned this morning from visiting Bart's Healthcare, which is another organisation with significant challenges. And one of the good things about that, they may have benefited from the visit, but I also benefited hugely from the visit. I benefited. It was great to see. It's inspiring, and it's fantastic to see. So it's a mutual benefit, actually.
I was at Bart's on Monday, so they're obviously getting a lot of regular warm visits from us at this stage, and I certainly agree that the heart hospital I went round was just absolutely fantastic in Westminster. So, good. Other questions of Jim in terms of his Chief Executive report, but wider issues on the issues that we're facing as a system?
I just wondered if there was any more detail on, or were you in a position to have any more detail on the impact of the strikes yesterday and the day before? Were there any occurrences of worrying? I know Kathy was on duty, I think.
Jim, do you want to start and then?
A lot of the focus will be on the tangibles, how many episodes cancelled, etc. And Kathy will cover it in detail. We've had no real serious safety concerns or any requirement for escalation. Kathy?
That's right. So we've obviously got early report. We've obviously monitored through the day, but there's obviously early reports of where things are up to. But the service seems to cope very well. There are some indications as well that some of the flow was better actually than on an average day. There was, I think we actually met the 95% A&E standard for 4 hours, which was not perhaps what's been happening on every day in the recent past, shall I put it like that. So that was good. There was some indication that both 111 and 999 calls were less. So the days themselves were managed extremely well. Lots of anecdote of good work going on in teamwork within the organisation. So all of that seems fine. I think the impact we will then need to look at is that on the cancelled operations. And we know there were 112,000 cancelled outpatients and also a lot of cancelled outpatient appointments and a lot of cancelled operations in some day cases. So we will obviously want to review that in detail. But in terms of safety, we seem to have managed. No.
Richard.
Just a quick question on the report, Jim. One of the things that you focus on is your meeting with your advisory group of chief executives, in particular topic conversation around moving something where success is measured and the benefits accrue to individual organisations to one that's based more on systems. Just a few reflections from you on how the chief executives responded to that.
Yeah. It's a good point, Richard. We started the discussion with me very much thinking that what they would want is things akin to the early FT regime where you got access to capital, you can make your own, all the things that we all remember, and it worked very well for a period. The bulk of the discussion from them rather than us was about the future is more about systems working together. So what they didn't really want, they wanted a bit of individual institution and autonomy. Yeah, but they very much wanted us to work out a system that actually supported people working together. So we've got quite a tricky balance to strike, I think, of encouraging individual pride and performance for the institution, but very much recognising that you are part of a local system and success is holding it all together. It's absolutely impossible to come up with any real solutions very quickly, so we've got some people working on it. It was a very rich discussion. I think a lot of it stimulated by early STP discussion as well, which has really made people think about how things might work in the future.
So it'd be a difficult trick to pull off. It's reassuring that was coming from them, not being pushed out there.
I was quite surprised actually, because I very much thought this was about, as I said, access to capital, being able to do things, have permission to do things, but that really wasn't the flavour of the discussion.
And very much reinforced by the chairs this morning about the importance of collaboration, the importance of the STP plans and making them real as opposed to just a process. And I think we'll come back to that in the development session. And just so that everybody knows, things that are covered by our development session will come forward to public boards once they've been developed. So we will have a run of things around our operating model, around our business plan, so that the public are aware of those things. But at the moment they're in development. Anything else for Jim at this stage? So can we get John? Is John Wilderspin? John, there you are. Sorry, you're sitting at the back. Come and join us. John has been leading for us the integration programme of bringing Monitor and TDA together with colleagues in the organisation and KPMG. And I asked for our first board to have a stock take of where we've got to. John, your paper. Take the paper as largely read, but of course highlight things that you want us to particularly focus on, and then I'll throw it open to questions.
Fine, that's right. So I was just going to highlight 2 or 3 things. The first is that this paper is deliberately looking at the work which has been done to date, essentially to ensure that NHS Improvement was in a position to start on its due date of 1st of April. This is a team effort, as been talked about earlier on. An awful lot of people that have done an awful lot of work on top of the day job to make sure that things were in place on the 1st of April to get started. So I'd like to take the opportunity to thank all of those people who have contributed to that. As I've said in the paper, understandably, most of the work that's been done to date is on what you might call the transactional issues, which were required. So as examples, a big piece of work around transferring staff from NHS England, where effectively we were transferring their employment. In the case of staff from TDA and Monitor, that wasn't an issue, but for staff coming in from NHS England, transferring their employment, big piece of work. Setting up new website, new communication for all those kinds of things. We've made a start, but to be fair, it is a start, on the more transformational work that's required to enable NHS Improvement to deliver its large and diverse set of responsibilities. So I think that setting up an organisation which is not technically an organisation, that's unusual. I've been involved in the NHS in setting up lots of new statutory organisations, but this is the first one where it doesn't actually have a statutory form. And combining responsibilities from regulation through to improvement, I think is a big ask, and frankly is quite a big cultural change. So made a start on that. Examples would be obviously the appointments of the new executive team, new operating model, which Ed's made reference to, and a very initial work on the culture and values of the new organisation. But I think that that is really the next phase, is looking at the transformational side, the organisational development side. And I should say that in terms of the work which has been done on the operating model and the culture and values, is that NHS Improvement brought in through a tendering process KPMG to help with that process, and they've been very much alongside people in the organisation along the way.
Thank you, John. I mean, it's absolutely essential we had some independent professional input to the process, but we have largely driven it ourselves, but with their support. It's a report of record, but just for the avoidance of doubt, these things don't just happen, and there's been quite a lot of hard work. So happy to take questions, observations, challenges to where we are from board colleagues, and in particular executive board colleagues who lived with it as part of the change process. Kathy.
So I think it does. You know, I've been involved in a number of these things, and they are a huge amount of work. There's no shadow of a doubt, and we're obviously making good progress. But I think one can reflect from the staff that, you know, the faster you can go, the better. There is a sort of sense of, you know, we've got quite a long way, as John says, you know, the board, the executive being appointed and so on, but I think the staff would say we would like to see this move as quick as possible. I think it is fair to say, but it all takes a lot of work, and as you're creating job descriptions and everything, you can feel that sense of work. But I think we have to recognise as the leaders that we need to support our staff through a difficult, can be a difficult, I mean, we hope it all lands nicely, but it can be a challenging period of time, so I think we should just recognise that.
Ruth and then Stephen.
I think, guess what I'm also hearing back from staff is about how we bring not just two organisations but also parts of NHS England with the Patient Safety Directorate. We've got potentially three or so sets of people, three sort of sets of culture, of operating practices, and there's a great opportunity actually to take the best out of all of those, to take the best out of what was Monitor, to take the best out of TDA, and create something really fabulous in NHS.
I think it's important to understand that both the operating model and the OD, the organisational design, is quite complicated, and we're not going to get this right, 100% right first time. I think Jim will agree. I think he does. That we may have to tweak bits of it as we start to work with this in practice, because, you know, we're going to talk about it later in the workshop, but some of this is going to be quite tricky, and it's important that we are flexible enough to make changes later in the year where we see things aren't working quite as we want them to work.
That's a point well made, Stephen, and I think where I sit on this is creating the agile organisation is part of what any organisation now has to do anyway, and we are no different to that. So it does require us to make a decision, to create the structure, create an environment where people know where they work, but also an expectation that where people work is not necessarily where they will always work, and to bring people together in project teams across functions, across parts of the organisation to do work, and then to form another project team and do another piece of work, as well as be very clear at dimensions on the matrix where those key points of intersection are. So Sarah and then Caroline.
I just wondered, in terms of the impact of the new organisation on the external environment, whether it's our trusts or whether some of the other major ALBs that we work with, whether we're delivering on time for them, and what sort of feedback we've been having about how that's gone.
So a big part of the work was going out and actually finding out the views of staff and the views of external stakeholders. And I think very significant, what they said was, yes, we want you to bring the best of TDA, Monitor and the teams which are joining from NHS England, but that's not sufficient. And I think Lord Darcy said at the launch of the provider roadmap, NHS Improvement has to do more than that. The clue's in the name. And it is about systems, not just about individual organisations. And I think that's where the transformational side of things comes, is actually getting people to continue to do well what they're doing well now, but also to work in a different way.
Jim, do you want to talk about the collaboration and in particular where we may go with appointments between us and other parts of the system?
Yeah, so there's two things. I think the service would see that it's very much a work in progress. So I think pretty broad support for the direction, but absolutely recognise that every interaction doesn't yet fit with that. And then we can see a lot of staff going through change and all those things. So the sooner we settle that down, the better, as Kathy said. With the other ALBs, I think it's actually quite complicated, because what we want to try and do is to build a lot of things together. So I had a lot of really good discussion with the CQC recently, for example, where I think our oversight mechanisms need to absolutely interlock with theirs and vice versa. There's no point us in forming a view on an organisation and saying they're fantastic, and CQC having a different view. So we need to have that as aligned as we can humanly get to. And similarly with NHS England, and there will be some shared appointments. We've already got agreement in principle of some of them. They're in hand now. Some shared functions we've talked about this week, some functions that are shared between all of the ALBs, where I think it's a huge opportunity. And hopefully get to the point with this work where actually we can agree there's one point of entry into a provider as well, because the big thing providers argue with us all the time about is there's just too many people trying to talk to them or ask them to do things, etc. So I think there's a bit of tidying up we can do that would be really helpful and productive. So it's a work in progress, so it'll take time, but we'll work on it.
Okay, thank you.
Caroline.
Two points really. One is just a sort of a challenge to all of us, I think, at the board and the executive level. And I think John put it very well when he said in all his time in the NHS he'd never been required to create a sort of non-organisation. And I think the risk is that we get bogged down in sort of processes, because we've got to keep on making sure we've done things as Monitor and what we've done as TDA and what the sort of statutory underpinning is for us. When actually what we want to do is operate as one board, and presumably the executive committee with the level of the challenge is the same, really driving change. So how we keep that sort of the bottom bit of the iceberg well underwater, but firmly there, so that we're not vulnerable, seems to me to be quite a challenge for how we work, and we're going to need lots of help. And I had one very specific question, if I may, which is that which is much more detailed about staffing. So in looking at the staffing and the structure, are there large numbers of people who are at risk of redundancy? Is that one of the problems, or is the problem that people feel uncertain about where exactly they're going to slot in?
So we're working in a context where not just us, but all of the arm's length bodies and the Department of Health are looking at reducing numbers over time. Right now, that's less of an issue, I think, than people coming into a new the organisation with still an emergent purpose, actually. So people have been used to being an organisation with very, very clear purposes. We're trying to blend that, and we're trying to layer something else on. That creates an uncertainty in itself. Change is always slightly like that. But inevitably people are looking around the public sector. You know, we are going through a big period of austerity, so that is in our minds. I think in terms of precisely what that will be, we're literally doing those numbers
And
right
the merger
now.
itself is not in itself creating a lot of redundancy, it's more the wider context of austerity.
And we're taking the opportunity, to be fair, of bringing organisations together, obviously, to make sure that we're running in as lean a way as possible.
And there's inevitability, Caroline, that when you've got two of something in two organisations, you only need one, then we have to either redeploy. And one of the things I'm very encouraged by is, you know, we employ smart people, but the jobs that they might have done might be different to the jobs that we might ask them to do. And to some extent that might be the type of job, it might be the location of that job. And in a way, Ara sort of slightly looked to you as chairing the improvement faculty. I mean, we have not got a significant amount of capability as yet aligned to an improvement agenda. So part of it is, where do we get that from redeployment or from bringing in, or how do we use the system itself to support that? I don't know whether you'd like to add to that.
Well, I haven't yet been in the improvement faculty, but I'll give it a try. I've had a discussion with Jim, and I think he is in the right place, is to see what's out there. I mean, I don't think the NHS lacks the talent of improvement. I think what it lacks is the environment to make that happen. And that is dependent on the actors in the landscape, from the regulators and others. So I think we have a bigger task in facilitating that culture of improvement, rather than necessarily the improvement skills out there. So and the only way to do that is to get our act together at the higher level of the system that could facilitate, if you like, the expression of that gene at a local level, and really translating that to the local needs, because the local needs are very different as well. Which brings me back to one point, if I could raise, is not the redundancy. Are we losing people we shouldn't be losing?
So you preempted something. I was going to go back to that very specific point, is that actually there's quite a high number of vacancies within the organisation, and some of that is, I think, the inevitable consequence of change, is that when you say to people that your organisations are going to come together and be different, some people will they'll go elsewhere. So I think that's so on the one hand that's a good thing, because that means that you're not looking at losing a lot of people. On the other, the danger is that you're losing people that actually you'd really like to keep and who've got the skills that you want to keep. I think I would say that actually the skill set that we need to have a lot more of is that skill in service improvement and facilitating change at a local level. We have lots of very, very able people with good technical skills, lots of people with experience of performance management, but actually getting those people and others with, if you like, technical improvement skills and facilitation skills. I think that's the big agenda.
Laura.
Well, just to follow on from that, and do you see therefore that those types of people with the technical improvement skills might be better off located regionally rather than sitting here in London?
And that has been absolutely part of the process. So I sat in the audience when Ed stood up, even before Jim had been appointed, and said to people, we are going to be a regionally facing organisation. And as
I didn't know that, but I concur.
Yeah, and Jim came in and he said exactly the same thing, is that we have to get alongside the service, not sit in an ivory tower.
Absolutely.
And to be fair, for those people who've been used to working in London, that has an unsettling effect, so we've had to deal with the consequences. But that's absolutely at the heart of it.
Okay.
The 4 regions are, in a sense, the building block of the organisation.
Sigurd, last point on this, I think.
It's just a related point, really. I think a lot of the people, is my sense of talking to folk around the place, who are still with us are here because they believe in what you and Jim have said about how we want the organisation to work. Regionalisation is really a part of it. It's all to do with the philosophy, and it's all that stuff that is yet to be worked out. I think we have quite a big body of people there who would like to believe that that can really happen, and we need to keep faith with them. And I think if we're going to start losing good people, it'll be because we have failed to keep faith with them.
Yeah. Right, I actually go back to what Ara said on this a few minutes ago as well, which is our people will be excited if our purpose is to increasingly oxygenate the system and get the system to do what the system can do with some help and support. And I think that is a really exciting agenda for this organisation, and one that I actually wrote a note on this morning, which is, why I'm here in a way, because my passion is how you create that oxygenation of systems whilst maintaining proper accountability, proper discipline around both money, quality and access. And it's a balance, but I think moving in that direction is a very important part of hopefully the strategy conversation we'll have later on in the afternoon. John, thank you for that, and rest assured, Caroline, I have Kate very close to my office when it comes to any matter to do with are we also fulfilling all of our statutory duties under the law. So we've got Catherine now. Catherine, welcome. Catherine, again, welcome. Catherine's Policy Director and has been very significantly responsible with Adrian for the development of this work in progress around the sort of update on NHS Improvement, and the way in which we'll come together later on in the development session of the board on the developing strategy. Again, take the paper as having been read, but any points you want to highlight, and then we'll open it out for conversation.
Sure, thanks. We'll just highlight this is a high-level direction of travel around what it is we want as NHS Improvement to achieve in the long term, in the short term, and how we go about doing that. As Ed mentioned, the opportunity for discussing some of the detail comes later on in the development workshops. But I just want to highlight that we absolutely recognise that we are uniquely well placed to help the sector address the challenges facing in the short term and the longer term, rising to the ask in the 5-year forward view. And we must make sure that we seize all the opportunities that being one single organisation creates. We set out some of the themes that will shape our work, the 5 themes that will shape what we do, and some of the short-term areas of focus around what we want to do this current year to stabilise the sector and to give it breathing space, with that real emphasis on, to use Ed's term a moment ago, oxygenating the sector, energising it, freeing it up to deliver improvement continuously.
Thank you. So questions on this broad framework, recognising that there's a lot of detail and a lot of hard work that will bring this to fruition. Do we agree the 5 principal overall objectives of 2020 around quality, finance, use of resources, operational performance, strategic change and leadership and improvement capability?
It's a question really of tone. In a way, we do need, and it's perhaps even helpful, to make it clear, because this will be in due course communicated externally, or certainly within the NHS, but also therefore externally, to make it clear to what extent there is a problem to be fixed. The document as written doesn't actually tip its hat very much to that. It talks about maintaining standards and then improving. One could argue that a little bit more of the sense of the burning platform might actually be more honest and possibly not unhelpful.
That's a good point, Jim. You might want to.
I agree.
I mean, certainly as we look at the next few months and certainly the objectives for 16-17, I think that what some people call grip, but prioritisation of absolutely what matters and how we signal that given where we are is going to be very important. Richard.
I'm happy with the content of the objective. And the other question I asked myself was, the subset of operational performance and that not being a part of quality. And I guess I mean I can accept this sort of structure, but taking standards around access away from the quality dimension doesn't feel right to me, to be honest.
I agree. We had quite a long discussion about this in the improvement faculty last week, Richard, where we can have very purist views on quality not really being related to money or operational performance or safety, and they're absolutely all hand in glove, aren't they? So I think that's something maybe explore in the workshop later on. It's a absolutely spot on point.
I think also when you show them as a list, that's the way it comes across, whereas I think a previous description of this in our roadmap was very much as a triple helix of interlapping objectives and stuff, and I think
that's why I think the content of words are fine, just the way you do lists and chunk it like that, it looks very stark.
So Kathy,
No, just I think it is really interesting about how we do present, and it's something that I think if you think of it from the patient perspective, which is a good place to think of it from really, is an operational performance is actually how long you've waited or whatever, and that's very much, if you look at CQC's 5 domains, responsive, you could argue, kind of encompasses. So I think it is presentational, but I do think it is helpful to think of what we refer to operational performance as actually part of a patient's experience in reality, and then it kind of keeps you in the right space with it, I think.
Good. So I think in terms of work in progress, and we'll get into the detail later, it's good. Jim is close to finalising his team of executives. We'll come back to that because other appointments are not yet announced. So good. The corporate report, you had a couple of points you'd like to...
I was simply wanting to make sure that a very important piece of the report by the committee that I had the honour to chair isn't overlooked, and it's this one here, the A3 sheet at the back end of that report. Because it's on a big sheet of paper and small print, it's very easy to overlook it, but there are 2 things I wanted to highlight for everyone, or invite you to go back and look at again, because if, like me, you read the report papers in a hurry late, you may have overlooked it. First of all, it's that on the left, it starts with the business objectives, which of course we will spend more time elaborating, but broadly speaking, I think we're all clear. That's what it's. One thing that was highlighted in the committee is the importance of the executives, as and when they are appointed, take ownership of those objectives and of making sure that they provide support to the enablers that are on the right-hand side of this, because without that support and engagement, you can spend all the money you like on IT and you will get nowhere. And so that's the one thing I wanted to highlight. The other is that if you look to the right, you see that most of the technical deliverables are in italics, which means that the funding for them are as yet not assured. Bob and I have had a conversation about that. He's trying to get money, obviously, from those that dispense such things, but that's clearly an important prerequisite.
Right. I mean, I think it's helpful. On the first point, Sigurd, you're absolutely right, and Jim and I are discussing executive team objectives. The executive team objectives linked to the organisational objectives, and then Jim's personal objectives, and then individual objectives. And the suggested format, but it's for Jim to do this, is one which sets the objectives, the measure, the dependency, which is a key part of this, on whom do I depend or on what do I depend, and then the evaluation. And it's that type of integration of personal objective setting with team objective setting with organisation objective setting. Sounds a bit processy, but actually it's how you get the glue together. So good. Thank you. So other than that, we take that as read. So this is the end of the formal matters on the agenda. Opportunity to ask questions of members of the public here. If you can just say where you're from and your question. And I have to ask you, are you in agreement with being filmed in asking your question.
Thank you very much, Chairman, and to the Board for the opportunity to ask the question. My name is Andy Taylor. I work as a policy advisor at the Association of British Healthcare Industries, which, despite its name, is actually concerned with medical devices, so we're effectively a trade association. We have, since the inception of more complex payment arrangements in the NHS, starting with payment by results, been a stakeholder, I hope a helpful one, for small but troublesome aspects of tariff, through the various advisory machinery in place, first in the Department of Health and then in Monitor. Those arrangements were set aside in 6 months ago, I think it was. So just to ask whether or not there are any clear plans for setting in place some form of consulting arrangements. This may not be the place to discuss this because pricing is on the agenda but not actually a discussion item, I see from the word you've used, so you may want to communicate it otherwise.
Bob, you want to make what comments are appropriate in this board, because I do think we should answer questions to the extent we can.
No, certainly. So, the development and continuance of pricing and payment mechanisms for the services continues to be a key responsibility for NHSI and a key element of the financial and business health of the sector. And we take that very seriously, and that's gone into some of our thinking about how the new structure will operate. I would certainly be of the opinion, having been associated with pricing development earlier in its gestation, that we want to have the widest engagement with stakeholders and the service and people associated with the service that is possible, to get the best outcome in what is an inherently very difficult area. And at the point in business cycle that we are in, we want to make sure we get it as right as possible. So I would like to see the engagement piece as comprehensive as possible.
And just to be very clear, and I'd say this, it would be better if we did not get to a situation where we got 2/3 of the way down the road and then stopped something, which was the case with HRG4 plus. But we are there, and we did it for proper reasons, and we have to then make sure that we move forward, having made that decision.
Thank you, Chairman.
So, any other questions from members of the public?
Hi, Ben Clover from the HSJ. I know, again, like in the private session, the third item after the Chairman's report, performance of the NHS provider sector, actual to end February 2016 and year-end perspective. Why is that in the private session? Is that not something that maybe should be shared publicly if that information is available?
I think where we've historically been on this, Ben, is issuing quarterly statements of performance, and the next quarter end is actually the March quarter end, which actually coincides with the year end. So our intent has always been to publish quarterly operational and performance data, but we have never historically provided monthly data, as far as I'm aware, in either organisation.
It didn't meet every month, I don't think, but when it did, it would produce like a month 10 thing, and a monitor wouldn't ever produce a kind of breakdown by trust, even quarterly. That would only ever be a composite thing. So I'm kind of curious.
Wait for the May meeting, see what we present at the May meeting, and then comment on whether you think that's a helpful both format and given that it is the full year numbers, a timely representation. To be honest, we are still developing monthly management reporting data as well. But do come back, Ben, as I know you will with whether the end of year one, and then I've asked Jessica as board secretariat to flag which board meeting will be the board meeting over the coming year at which the quarterly results figure. I will defer to the chief exec to propose, if we cover more regular reporting, whether we put that in the public or private session.
Right, I was curious why you wouldn't make it public if you've collated it.
I think in terms of the February results, they are, you know, we're now at the end of April. It's pretty historic for one thing. Two, it's this one particular set are very close to the year end, and because of that, there's quite a lot of movement activity in that period. Jim, I don't know whether you want to.
Yeah, I think it's just we're in transition. We haven't had the discussion yet about frequency of reporting, so we've just been finishing off the old reporting cycle as best we can. And we'll start the new year afresh. We'll have a discussion about whether we do that monthly or quarterly in the new year.
We will. I mean, it is a fair question, but I will just say, in just for the avoidance of doubt, there is absolutely no pressure from anywhere for us not to report publicly, whereas there was a bit of a suggestion around early last year that might be the case. This is not anything to do with other than our own maturing organisation, and we will, as Sigurd and Jim said, reflect on it. Okay. Thank you very much for your attendance, members of the public, and for those who watch the film after the board meeting. I pass now the private resolution that other members of the public and the press are excluded as we move into private session. Thank you for your involvement, and we'll take a short 5-minute break whilst the room is rearranged. Thank you very much.